Hello everyone, my name is Prakriti and I'm going to be talking about the drugs that we use in Parkinson disease. But before we do that, we need to know a little about the defect that occurs in Parkinsonism. The defect mainly occurs in the nigrostriatal pathway, where, in, where basically the dopamine and acetylcholine uh, both act via different neurons on the corpus striatum, and depending on which neurotransmitter is acting, they either decrease or increase the release of inhibitory GABA neurotransmitter. Now, in Parkinson disease, dopamine is produced less in quantity. And hence, in very simple terms, we can say that there is an imbalance between dopamine and acetylcholine. Now, this imbalance results in the patient coming with rest tremors, rigidity, bradykinesia, which is slowed movement, and gait impairment. Pathologically, what we see are Lewy bodies, which are nothing but inclusion bodies present in in the cytoplasm made up of proteins called alpha synuclein. Now, how we manage the patient is that right now, since there is no cure for the disease, we try to alleviate the symptoms of the patient by correcting the imbalance between dopamine and acetylcholine. So, what we try to do is increase the brain dopaminergic activity or decrease the brain acetylcholine activity or muscarinic activity. Now, what are the various points at which the dopaminergic drugs act? Like we all know, dopamine acts on the dopamine receptors. So we can give drugs that also act on the dopamine receptors or are dopamine agonists, in other words, which include drugs like bromocriptine, pergolide, pramipexole, ropinirole, etc. We also know that dopamine is metabolized by enzymes like monoamine oxidase or catecholamine or methyltransferase. So what we can attempt to do is inhibit this metabolism so the overall amount of dopamine in the brain increases. Using drugs like tolcapone or for MAO-B, we can use MAO-B inhibitors like selegiline and racegiline. But the big question that arises here is why can't we directly give dopamine? And the answer to that is simple. The dopamine does not cross the blood-brain barrier, and our site of action of the drug is the brain. So here what we make use of is the fact that levodopa is a precursor of dopamine and it's converted to dopamine by the enzyme dopa decarboxylase. And levodopa does cross the blood-brain barrier. But unfortunately, this levodopa also gets converted to dopamine peripherally, that is outside the brain, and this dopamine will cause unwanted adverse effects. So to curb the peripheral conversion of levodopa to dopamine, we co-administer peripheral dopa decarboxylase inhibitors like carbidopa along with levodopa. And to increase the availability of levodopa in the brain, we try to inhibit the metabolism of levodopa peripherally by giving COMT inhibitors again, like entacapone and tolcapone. So this is a very brief summary or synopsis of the dopaminergic drugs. Now, starting a little in detail about levodopa, we have already seen the mechanism of action. What I would like to point out here is that peripherally, the reaction of conversion of levodopa to dopamine is enhanced when pyridoxine is co-administered. And this leads to increased dopaminergic adverse effects in the periphery, like tachycardia, nausea, vomiting, alteration in taste, sensation, etc. So we should avoid co-administration of pyridoxine and levodopa. Moreover, the nausea and vomiting caused due to dopamine peripherally should be treated with domperidone because it acts on the CTZ and does not cross the blood-brain barrier. Whereas metoclopramide should be avoided, should in fact not be used absolutely because it blocks the dopamine receptors after crossing the blood-brain barrier, and hence the whole point of the exercise of increasing dopamine in the brain, it becomes fruitless. There are some long-term adverse effects of levodopa as well, like the on and off phenomenon, which occurs when the medication is given, the symptoms of the patient are alleviated, the patient feels good. As soon as the medicine starts wearing off from the plasma, as it approaches more than 40 hours, the symptoms begin to return and the patient feels worse. And this becomes a cyclical process in a very short period of time, which is known as the on and off phenomenon. Now, the other long term effects include behavioral effects like mild anxiety, nightmares, sometimes hallucinations, etc. And hence, it is contraindicated in psychotic patients. It may also cause dyskinesias, which are abnormal movements like facial tics or grimaces, like something like this. Other adverse effects include postural hypotension, which is said to be a central effect of dopamine, and it may even exacerbate angina peripheral. Now, most of the peripheral side effects can be countered by the use of peripheral decarboxylase inhibitors like carbidopa and benserazide. Usually, the regimen we prefer is levodopa and carbidopa in a ratio of 10 is to 1 or 4 is to 1. We can also give dopamine agonists, like we already spoke about, which are longer acting D2 agonists. However, they are expensive, higher doses of them are required, and they might cause a marked fall in BP after the very first dose, especially bromocriptine, which was used earlier and it was an ergot derivative. But nowadays, ropinirole and pramiprazole, they are non-ergolic and they cause very few GI symptoms, especially ropinirole, which is also the drug of choice for restless leg syndrome. However, because of the various adverse effects, we mainly use this as a supplement to levodopa therapy so that the levodopa dose goes down and the on and off phenomenon and other adverse effects of levodopa are reduced. Similarly, MAO-B inhibitors like selegiline and rasagiline, which reduce the intracerebral degradation of dopamine, are also used as an adjuvant to levodopa. The important point to note over here is that selegiline is sometimes metabolized to amphetamine, and that may cause insomnia and agitation. Hence, it is contraindicated in convulsive disorders, which adverse effect is not present in rasagiline, which is a newer drug and also 5 times more potent. And hence, among the two, rasagiline is more preferred. Coming next to the COMT inhibitors, what we might have easily missed from this diagram is that tolcapone is present both in the brain and peripherally, whereas entacapone has a purely peripheral action. It has peculiar side effects in that it causes diarrhea and yellowish orange urine. Moreover, because it is increasing the peripheral levodopa concentration, it will also worsen the adverse effects caused by levodopa. Again, here it is used as an adjuvant or supplement to levodopa, especially in the later stages. It's not at all indicated in the earlier stages of the Parkinson disease. Talking about this very interesting drug called amantadine, it was ideally an antiviral drug used for the prophylaxis of influenza A, but then it was found out of serendipity that it promotes presynaptic synthesis and release of dopamine, and hence it is also helpful in Parkinson disease. It's sometimes used in milder cases. Again, the peculiar adverse effects caused by glutamate antagonists like amantadine is vasoconstriction post-capillary. That is the venous vasoconstriction especially, which causes livedo reticularis, that is bluish discoloration of the skin, and edema of the ankles. Coming to the drugs acting on the brain cholinergic system, there are certain drugs that can induce Parkinsonism by occupying the D2 receptors. These include antipsychotics and metoclopramide. We've already spoken about metoclopramide. Now, because these drugs induce Parkinsonism by blocking the D2 receptors, there is no point in increasing the dopamine in the brain. So what we try to do rather is reduce the acetylcholine by giving central anticholinergics like trihexyphenidyl. The adverse effects obviously will be more of the sympathetic reaction type. So they will cause urinary retention, dry mouth, constipation, blurred vision because of loss of accommodation, etc. You can also give antihistaminics with high antimuscarinic properties. Again, you will have sympathetic adverse effects, but apart from those, we will also have sedation and dizziness, and hence the patients should be asked not to drive or do any other work that causes excess of that requires them to be alert most of the times. Example of this drug is promethazine. So this is a very short and quick summary of what we have discussed already. the mechanism, drugs acting on the brain dopaminergic system, the brain cholinergic system, and the reason why we are trying to do that, some important adverse effects like the on and off phenomenon, nausea, vomiting to be treated with domperidone, some important points, contraindications, etc. These are the references I made while making this uh, presentation. I hope you all liked it. Thank you for watching.